Awesome. Thank you for your time. Nice to meet you virtually. Sorry, I can't be there in person. My name is Arjun Panesar. I'm the founding CEO of a company called DDM Health. We were founded technically 20 years ago when my grandfather was diagnosed with type 2 diabetes after a quadruple heart bypass. And I was studying for an undergraduate master's degree in AI at Imperial College at the time, in late 2002. I'm from quite a multicultural family, and he wasn't sure what he should eat. He's of Bengali sort of background. My grandmother is white British, and sort of we're mixed and everything in between. And as a mixed family and an Indian family, we celebrate food a lot. And my grandfather was stuck on what he should eat. He asked me what he thought he should eat, and I had absolutely no idea. But I said, this really cool website called Facebook has just opened up at university, so why don't we ask the internet? At that point, we founded what has gone on to become one of the world's largest diabetes communities, or communities for people with long-term health conditions. And from that, over the last decade, we've been developing digital health services for patients, used not only in the NHS, but a number of other territories as well. I'm going to talk a little bit about how we make digital health accessible, and then how we personalize and create individualized experiences, starting from the data that we're collecting, moving into the platform, and then the outcomes of some of the interventions and some of the programs that we see. Rather than doing a bit of a demo of the app, I thought I'd also take you through a few key screens in order to describe and explain how elements of behavioral change are A, engaged with patients, but then B, how we're able to then sustain those long term. So I'm sure I don't need to tell you about the spiraling costs of healthcare, but there are some things that I think people are often unaware of. Firstly, the fact that NCDs, or non-communicable diseases such as obesity and type 2 heart disease, cause almost 9 in 10 deaths, depending on where you are in the world. And unfortunately, your neighborhood, your income, and your ethnicity make the biggest difference as to whether you will engage with health services and whether you will receive health outcomes from them. So that's really where our ambition is to empower everybody, and sort of diversity is really a core theme of what we do in order to lead a healthier life. We do this with AI-led digital therapies, or digital therapeutics, that we've developed with a number of clinical teams, but patients as well. Rather than sort of talking about the intervention as a sort of an intangible concept, I thought I'd sort of just highlight some of the areas where we've been able to use these sort of personalized interventions. So I think firstly, obviously, there's huge opportunities with patients who are within primary and secondary social care services or service users. But then we've also been empowering workforces or sort of communities that are looked after in some form or another. So we've done some really interesting work with bus operators and Transport for London, for instance, and local authorities and NHS bodies, in order not only to empower the patients or the users that they look after, but also the people who are delivering that care as well. At its heart, the Grow Health intervention is a behavioral change platform, and it's a precision behavioral change platform, which essentially means that the data that is collected on sign up and the data that is collected as users continue to engage with the platform, their behaviors, their phenomics, all of that data is captured in order to personalize the patient pathway. Obviously, we're providing monitoring in terms of home monitoring support, but the ability, or sort of the opportunity with technologies like this, is that we can enable health self-management and reduce health inequalities. And I'll go on to touch on a little bit more about that shortly. The Grow Health app, I'm really pleased to say, is the highest rated Orca health app. Orca, you may know or have heard of. They're a body who review apps on behalf of the NHS. And they look at 3 key core pillars of what an app or what sort of an intervention should contain, and that's clinical assurance, which I'm really pleased to say we scored 100% in, data privacy and security, and also the UX, or the usability as well. The platform is also NHS certified. In order to make behavioral change ubiquitous, we've made a multimodal or a multi-system app. So it's not just on mobile, it's on the web, it's on smart speaker, it's on smart TVs, and we also have packs for people who are digitally excluded. And I'll go on to touch on how we do that a little bit later. At its heart, once you go into the platform, we're able to cater for 15 health conditions, and we're able to do this in a number of languages. So cardiometabolic health is a sort of a core stream of what we provide in terms of obesity and pre-diabetes and type 2 diabetes support, but more recently doing a lot in regards to healthy aging, social care, and in particular veteran health. This document gives you, or this slide rather, gives you an indication on what the customer journey or user flow looks like. So you can see here, on day one, a user is referred to grow with type 2 diabetes in this instance, and they may have been referred to grow by their GP or their primary care physician, or they may have been diagnosed sort of in a mobile sort of well-being workshop at work. On the same day, that user will be enrolled into the platform or can be enrolled into the platform, and we, in some instances, would conduct a finger prick blood test in order to collect some blood markers that would be used in order to personalize and individualize the care that will be received. We have the opportunity to digitally ensure that we're able to cater for the medications that are required, and if any diagnostic tests or assessments are required, they can also be booked at that time as well. From that moment, the care is personalized to not only David's current health, but the behaviors that he exhibits as he continues to go through the platform. We have the opportunity to speak to a virtual GP every 90 days, coinciding with A1C tests or sort of blood glucose marker tests that would be conducted in order to understand the state of the user's health, but then in order to then further personalize the treatment that user will be sort of receiving or that they will be on. And I'll touch on sort of how we do that shortly. Home monitoring plays a big part, and this is where sort of the datafication of life. It's not just clinical health records we're looking at connected devices, synced wearables, and food diaries where you can take photos, similar to Instagram, where we're more realistic in terms of what's being eaten, rather than sort of missing out perhaps core things on someone's plate. And what we've been able to demonstrate in 14 studies to date is that we can improve health outcomes. We do all of this by utilizing the combi model of behavioral change. And my colleague has worked on a behavioral change architecture over the last 7 years, which really is looking at developing the capability, motivation, and opportunity, and ensuring that they are right in order to engage someone in a behavior. And we do this by starting with goal setting. So up in the top left, you can see that we have patient-centered, solution-focused goal setting. We use this in order to anchor where the patient would want to be, and then provide individualized education that is tailored to the user's demographics, their health conditions, and their goal. This would be delivered in a native language. So if I chose Punjabi, for instance, I would receive it in Punjabi. And the whole platform would be delivered in that native language as well. So you wouldn't see any English, and the coaching you'd receive would be individualized to your preferences. You receive community support, and this is from a peer-to-peer moderated community. You're able to track your health, as I mentioned, and then the resources you receive or the rehabilitation support that you will receive as you go through the program is completely personalized to what you have shared. So based on your allergies, your preferences, you would receive meal plans and recipes. Workouts would be tailored to your fitness level, and things that are there to support your mental well-being. For instance, mindfulness and meditations and yoga would be tailored to the ones that you prefer and the activities that you enjoy. We then have one-to-one health coaching, and then a behavioral change pathways where I become more excited. That's looking at the health and behaviors of users and then nudging them back into the platform. All of this data is collected in a provider platform that provides individual level data for clinical teams, but more importantly for us, service data, which is able to decipher how well someone is using the platform, whether they're engaging with it. And we use that again to nudge people back into the platform and aspects of the app that would suit them or that they'd like. If people can't get online, and we service a number of communities where there is a huge digital divide, we have a digital exclusion pack. And at its most basic, that's a program manual of the education you receive, some DVDs and telecoaching, which you'd receive by phone. So In order to provide personalized or individualized care, we have broken down health into the 4 key modifiable risks: sleep, nutrition, activity, and mental well-being. And then the state of care is then delivered around that. So to give you an example of someone who is diagnosed with, let's say, for instance, bladder cancer, they may receive the app and have a sleep program. They may be following a lower carbohydrate or ketogenic diet approach within the nutrition section. They may have a very bespoke activity program, and there would be well-being support that would be very focused towards their care that they would be able to experience as well. And almost just to run you through sort of just a couple of slides, won't bore you too much, but you can, there's a few app screens here that kind of just demonstrate how this is presented. So you can see we have a screen on the left where education is provided or sort of visualized to the user, and you can see how users can choose their nutritional approach, or it can be set by their clinician. And then they essentially run through this cascade of education, action points, resources to support their learning, a quiz that understands their behaviors and then nudges them back into areas in order to improve skills and confidence, and the ability to check in with their health. The same thing runs true for mental well-being, where for me, where it becomes exciting is things like guided meditations, where we'll be able to use the power of augmented reality. I've already talked a little bit about the tailored exercises and activities. And then moving to sleep, things like bedtime meditations, sleep music, bedtime stories are all very useful in order to really create that holistic sleep program. We then have counseling that's either conducted by a dietitian, by a psychiatrist, by a psychologist, or a personal trainer, depending on your needs. And then, as I mentioned, a community forum where we're looking at building long-term relationships. More specifically, when we're looking at accessibility, one of the first things that we have learned is that unless we speak the language that people are speaking, they just won't engage with services. So we spend a lot of time working with a number of community groups, and as part of any implementation that we would conduct, we would typically conduct some PPI to understand the local needs, not only with the commissioner and local groups, but patients sort of grassroots as well. And through this, we've been able to develop really iteratively the program to support 19 languages. You can see the languages there at the bottom, and sort of more excitingly, you can see on the sort of the bottom right what this looks like. So you see a very similar platform. The whole experience is exactly as you would expect. However, it's just tailored to your language. It's localized and it's adapted to you. So it's not a straight Google Translate. This is where we have localized, say for instance, in nutrition. People like my grandfather would be being told about chapatis and Weetabix in the morning rather than sandwiches, and he would be being told that in Bengali as well. We then move to faith sensitivity. So, for instance, with particular faith groups, there may be particular foods that we may not eat, and that is all catered for, not really with AI, but with just basic data science. And then, for instance, people of an Islamic faith may prefer female-only exercise classes, and these kinds of things are facilitated as well. Accessibility is huge, particularly post-COVID. It pushed everyone online and really highlighted some of the key inequalities that exist. And so one of the things that we have really focused on is how we can ensure that we can reach as many people as possible with one unified platform. We support visually impaired users in a number of ways. There are particular compliance regulations or guidelines that we adhere to, but more importantly, it's accessible with a number of screen readers. You can engage with apps. You can make the fonts bigger and smaller, which is very important for people. And you can decide how you want to engage with the content. So for people who are visually impaired, they can just listen to it if they wish. They can stream it on their Amazon Alexa, on their Google Assistant, and they can use it within their own Google apps and within their own Alexa apps as well. You also have the ability to stream the app to the TV. And whilst it seems as though this would be really futuristic, we actually have 3 deployments in care homes where they use a phone and stream it to the TV. And we've got photos of 12 elderly people working out to sort of a TV. Hearing impaired users are supported with subtitle videos. They also have BSL interpreters, or BSL signed videos rather, and physical learning materials. Digitally excluded users I've touched on, but what's been really interesting is in a number of communities, we see digital exclusion at around about 50%. So whilst we talk about the future of digital health and precision health, there is still some way to go in order to really cross that divide. If there are other needs or other difficulties or accessibility requirements, that's when things become tailored. So dependent on whether you are able to access via the internet, via the web, or you're with a carer, or there are particular sort of accessibility requirements that would be taken care of in an initial appointment. And then we would tailor that intervention to you, making sure, for instance, if we needed an interpreter or translator, they would be present. And carers have the ability to access either on behalf of their user or have sort of a guest account. And then finally, in order to make sure things are accessible, we have a free phone number. And whilst you would think that with the digital app, everyone would have questions and email them online, you'd be surprised that around about 70% of our queries come on a telephone line. And surprisingly, they're very digital questions, such as how do I reset my password? Moving more towards the future of health and things that really begin to excite me is how we can make health smart. So whilst we have a precision health platform and it is delivered through a number of smart devices, looking forward into the future, the ability to access this from things like your car, from your home, are becoming very real. We've recently been part of the Scotland 5G Accelerator, where we've been working with a number of phone networks and local communities in order to build the infrastructure and support in order to deliver these kinds of interventions. And this is really important because 60% of older people over the age of 65 don't have access to a smartphone. They may have access to the internet, and they may have access to a smart device, but they don't actually own a phone in which they can download apps and sort of use them. So this is where, when we move to Alexa and we move to voice-activated assistants, it becomes really interesting. We've just started some work that's been kindly funded by Innovate UK, looking at how we can use someone's voice in order to personalize their rehabilitation from long COVID. We're working with the Royal Holloway, University of London, in order to understand not only the emotions that someone's expressing from the voice data that's collected, but crunching that alongside their clinical data and wearable data in order to get a picture of their state of health, connect it with their voice, and use that in order to support other people in symptom monitoring for long COVID. So digital health is all well and good, but it's only good if people use it. So I'm really pleased to share some of the outcomes, and we really split this into cardiometabolic health, so weight loss and looking at pre-diabetes, type 2 diabetes, mental health, and care efficiency. Starting with weight loss, what we've been really surprised by is that long-term engagement with the solution is a lot higher than we expect. And as a result, we've been able to collect follow-up data at a year in collaboration with the local university hospital here in Coventry. And we've been able to demonstrate a between 4.5% and 7% weight loss if you are within tier 2, tier 3, or tier 4 weight management. And then moving into pre-diabetes and type 2 diabetes, really, really exciting results. We're able to see almost 2/3 of people with pre-diabetes achieve remission, and people with type 2 diabetes at the end of a year are able to reduce their medication usage by around about 60%. And 1 in 4 patients is technically classed as being in remission. And this is through a completely digital, remote, automated solution that has redefined really sort of the understanding of wellness, at least in type 2 diabetes. It's only 2 or 3 years ago, you have to look back, when type 2 diabetes was considered a chronic and progressive disease. So it just goes to demonstrate the power of data, the power of evidence in redefining some of the sort of the understandings and definitions that we have today. Moving into mental health, the outcomes that we have here, we're looking at 12-week follow-up, and we share baseline standardized questionnaires for stress, anxiety, and depression, and life satisfaction at baseline, and then every 12 weeks. Really pleased to say we see a reduction in all three in terms of stress, anxiety, depression, and that's been measured by the GAD, perceived stress, and PHQ questionnaires. In regards to life satisfaction, that improves as a result of using the app. And I think that's as we would expect. People are losing weight, they're improving their mental health, and as a result are sort of enjoying and have improved their life satisfaction. We also see an improvement in health utility and chronic pain symptoms as well, and perhaps linked to weight loss that may be associated with the app, but also with users who aren't using it for weight loss. We see these improvements as well. There are huge benefits to realizing digital health, and I think this just highlights some of them. We're able to see almost 9 in 10 people accept signposting for digital health services, and this is unheard of. And when it comes to ethnic minority communities, we see a 66% greater acceptance from a community that have been typically considered hard to reach. I'm really pleased to say, when looking at digital literature, it's the highest signposting we see from a ethnic minority community, and I put it all down to the fact that we're speaking the languages that these communities speak. And as a result, we see almost 9 in 10 people stick with the app at 12 weeks, and 7 in 10 patients, or 7 in 10 users rather, stick with the app at a year. We've been doing a lot of work with University Hospital Coventry and Warwickshire, where we've been lucky enough to team up with a clinical entrepreneurial fellow and TOPL fellow in order to evaluate and personalize our platform to deliver the care that they would like to deliver in the hospital. I'll go on to and end with just the case study that we've developed there, but we were really, really pleased to demonstrate that the care we were delivering during COVID was compared to a control group and demonstrated to be equivalent, if not superior, to face-to-face care. And I'll end with that. And then in terms of cost savings, we've been able to demonstrate a significant cost saving in type 2 diabetes medications. And this is really redefining the way that we can commercialize and model some of these things. So not only do we have the ability to price this on a per user license, for instance, we've been doing a lot with the NHS in regards to sharing outcomes or sharing sort of the gains from reducing medication, for instance, and improving or reducing the number of people in emergency admissions, for instance. And then finally, before sort of taking any questions, just wanted to end with the case study I was just talking about. When COVID kicked in around about March of 2020, I think it was a pandemic on January the 30th, and then sort of by the end of March, diabetes services had all stopped in NHS England, and a number of hospitals, number of primary and secondary care services needed to think quick in order to how they were going to service their communities with obesity, and in particular those who were severely morbidly obese. And so, as I mentioned, we've been lucky enough to team up with the University Hospital Coventry in Warwickshire, and we just so happened to have launched the app. It was just fortuitous, the fact that we were launching it in April when all of the referrals stopped. And then the app was used for, and it's still used in the hospital, but for the purposes of this study, we looked at outcomes at, I think, 7 months. And it was really inspiring to see that whilst people were struggling with obviously engaging with the face-to-face service, by using the digital service that we were providing and having a remote checkup, as if you may remember from one of the first slides, just nudging that user back within their clinical team back to have a sort of a remote appointment. Combining the app with these remote appointments was able to achieve a almost 3 times greater weight loss and almost 3 times or 4 times rather greater A1C reduction in patients who were using the app compared to the control group. And this is with a community who don't speak English predominantly, or almost rather 40% of users didn't speak English as a first language. And so hopefully what this really underlines is how we can use digital services to make digital access democratic and also enable these communities that have typically been hard to reach, but really aren't, because my grandmother's probably sitting on YouTube right now, in order to engage with these health services and benefit from them. That's all I had for today. Thank you, and I'm really happy to take any questions.